Joints, talk about the joints, joint capsules, ligaments. Several named modes of therapy involve joints, lots of them actually. Manipulation, joint mobilization, alignment, remodeling of collagen, and even exercises are the main ones. Any muscle lengthening procedure will involve joints as well. This section will demonstrate one way of assessing and treating them. Ligaments and joint capsules that span the joint and the bone on either side are all actually part of that joint. As an embryo, as an early embryo, all these above structures, including the joint space, were one enlarge. That is a common mold of mesenchymal cells. Therefore, one part of the joint alone can't be affected without involving others. The bone will be discussed in another video. Only a few samples are shown here. How joint mobilization fits in into my idea. We hold the joint at the end range, and it's not always a normal physiological end range. I'm going to give you an example on the shoulder. How to do the joint when scar tissue remodeling fits in, and we're not always on the physiological range. We'll talk about the shoulder there. And we'll talk about a little bit about the shoulder, the elbow, the wrist, hip, knee, ankle, lumbar facet joints, and the ligaments. Remember, nerves are in these structures as well, especially after an injury. Many of the problems exist where the ligaments and joint capsules join the bone. That's the enthesis. Most of your problems happen at the enthesis. Only the soft tissue aspect of the enthesis will be covered here. In all these techniques, the position has to be held long enough in order for the fluid to move. Speaking about the joints, we always talk about range of motion of the joints, joint mobilization. I'm going to introduce kind of a new idea or a bigger idea about joint mobilization or range of motions of the joints. If you consider, let's talk about shoulder joint, for example. Range of motion of the shoulder joint, let's do a scratch test. As far as you can back up there. And then this way as far as you can right back. Scratch test. And you can do the range of motion this way. It looks like the common range of motions of the shoulder. Physiological range of motions of the shoulder. I'm telling you the range of motions is almost infinite for any joint. I know the shoulder being most mobile, most infinite. There's also a range of motion, for example, if we internally rotate the shoulder and then add some traction upwards. Or if we externally rotate the shoulder, traction upwards, traction downwards. Those are two new ranges of movement, but they're not really physiological ranges of movement. The other things, we can push straight backwards on the shoulder joint, and we can do this internal rotation, push straight backwards, or external rotation and push straight backwards. Different ranges of motion. Or we can move forwards, internal rotation forwards. Many different ranges. Now, when we talk about shoulder, I know with chronic shoulder problems, everybody talks about like a collagen, scar tissue remodeling, breaking down scar tissue and having it aligned in the correct planes. When we do those procedures, we go to the end range and the physiological movements of the shoulder. Physiological movements of the shoulder, again, would be like the scratch test. Hand behind your back, this one, all the way up. And as the range of motion of the shoulder increases, the hand goes up more, and this is the idea is to remodel the collagen. And this way here, goes back like this. And you can go forward. Physiological ranges. Now I'm going to introduce you to a different idea, a new idea. Now, collagen remodeling works. It works great. But a lot of people I think you're doing collagen remodeling for is not really as effective as you want to be because you're not really going for the problem per se. And the problem is with collagen and with scarring. You have a lot more pressure in the tissues there. Because when these proteoglycans, I mentioned before, these proteoglycans absorb a lot of fluid, and when the nerves and the connective tissue are under stress, proteoglycans are formed. These proteoglycans can hold 50 times the weight of water molecules, so when the proteoglycans are loosely bound to the nerves and connective tissue, the water comes around there, pressure goes up, fair amount. But when you have collagen and scar tissue with the proteoglycan as well, instead of that complex holding 50 times their weight, it's over 1,000 times their weight, so it's a huge difference. So the idea is when you have scarring or injury with proteoglycans, the pressure is really high. Now the goal of therapy is to drop the pressure down, and by increasing the pressure, indirectly we increase the pressure on the affected part, that moves the fluid out then the pressure afterwards is going to be decreased and blood flow is going to be restored. Now this way we still load collagen, that's true, but not necessarily in the physiological range. The range I'm going to use is the one that reproduces the patient's symptoms because I know I'm targeting the area involved. Now, for example, with the shoulder, I want to move it in such a way that the affected area, the pressure is going to increase during the procedure that causes the fluid to move out. Took me a long time to figure this particular one out, and people all over the world are doing it now. I hope you get the idea. So yeah, just put your arm over me like this and drop that down. Now I'm moving the head of her humerus up towards the ceiling, and that's a different range of motion. Just keep your feet down. It's a different kind of range of motion you don't find in the book. But for her rotator cuff, for the scar tissue or the edema around the rotator cuff, this is very effective in a lot of conditions because we're going for the idea of increasing the blood flow by decreasing tissue pressure so the tissue pressure gradient's restored. Okay. As I demonstrated in the shoulder, so goes true for any other joint regarding range of motion, regarding scar tissue, collagen. Let's look at the hip joint. We know the functional physiological ranges of the hip, but we're looking for that area that reproduces the pain. We're looking for the target tissue that's the cause, the generator of pain. It's interesting, because we have a pathoanatomy, I know what the pathophysiology is. Many, many papers on the website, you'll see the pathophysiology. Once I know that is and look towards that, the actual mechanism of action is proven, because we know that force causes fluid to move. Non-Newtonian fluids, some of these particular proteoglycan fluids, they also will go under the property to shear thin. So when we put pressure onto that area, the fluid is kind of in a gel form, but becomes thin as well, so it's more easy to, or in other words, the viscosity will decrease and it more easily exits. So this is kind of what we're looking for. So if we're going to joint capsule of the hip, say, or say ligaments around the hip, range of motion of the hip. Okay, so first of all, with the belt here around the SS, I can hit some traction, or I could do some external rotation, or I could do some internal rotation. As I mentioned in the shoulder, in the beginning of the shoulder one, you know, the different directions and different positions, there's a lot of them for the hip, and the one that's right is the one that reproduces her symptoms or the one where she feels a change. So, external rotation, full flexion, halfway, external rotation. You might want to do some external rotation with traction, all on the hip. Abduction with internal rotation. Abduction, internal rotation, traction. Abduction, external rotation, traction. The hip joint itself, I might want to move the hip joint this way. So I brace the leg across. I always ask permission because we're getting close here. And external, I'm moving the joint laterally. I'm moving the head of the femur laterally in relation to the acetabulum. And I can do that with external rotation, or I can do that with internal rotation. I can move the hip the other way. External rotation, move it this way. Internal rotation, move it this way. I can move the hip in some extension as the hip's same ranges of motion. Going to the knee, flexion, extension of the knee. We can have internal rotation of the tibia with some flexion, external rotation of the tibia with some flexion. We can do some traction on the knee, traction, anterior traction like a drawer test, or we can do posterior traction like in the drawer test. We can do some internal rotation of the tibia on the knee with posterior and anterior traction. We can maybe have the knee less flexed and do the same thing. Ankle, same thing with the ankle. Can I take your shoe? Inversion, eversion, supination, pronation, external and internal rotation, hind foot, forefoot. Dorsiflexion a little more. Which bone are you affecting? Which tarsal bone are you affecting? Which metatarsal bone are you affecting? Or even the phalanges you're affecting? I don't know precisely. I'd like to know precisely, but basically what I'm saying is the patient directs me to the area of concern. These mobilization techniques are these loading techniques of the joints and the holding elements around the joints, quite often are associated with chronic conditions. They don't heal because the blood's never gotten in there. Okay. These next procedures just demonstrating something about the ligaments in the joint. As I said in the beginning, that you really can't affect one part of the joint without affecting the holding elements in another part of the joints, because of the embryological origin, they're all part of one. The interzone comes in, it was all one end ledge. The interzone comes in, that causes the bones to separate, or space between the bones, and the ligaments remain. Joint fluid goes in there, synovial membrane. So we're going to take a look at, let's suppose you have a chronic problem you can't solve. It might be a case where the ligament joins the bone, the enthesis. Ligaments cross the joint, it might be where the enthesis. You might think it's tennis elbow, but perhaps it is. Perhaps the idea of what a tennis elbow is limited to some of the conditions that can cause pain there. You come in close on this? So let's look at the ligaments on the lateral side of the radial side of the elbow. We can load those ligaments. I'm going to push down. You all right with that? Now, if I can reproduce her pain, of her elbow, I know I'm targeting the tissues that I want. I can give it some traction, and then I'm stretching the ligament. Same thing. Flexure aspect of the tendon. Flexure aspect of the elbow, or the ulnar side of the elbow, ligaments on that side. A little bit of traction, and I might change the position just a little bit, which I do, so I reproduce the symptoms. Let's go to the knee. IT band. How many IT bands have you seen you can't help? You just say it's an IT band, but you can't help. Well, perhaps it's a ligament problem. Just because the pain's down there doesn't mean it's the IT band. Or maybe IT band syndrome involves other things in that we know of. So if I want to load the ligaments on the lateral side of the knee, and I can change the position of it, traction. I might want to change it to a little bit more. Okay, and traction, maybe some internal rotation. Feel that on the outside of the knee? Can I go a little further? Same thing, it might be ligaments on the inside of the knee. Maybe the pes anserenus, as you thought it was, maybe it's more of a ligament enthesis problem. Been my experience, though, when you talk about the inside of the knee or knee pain, quite often the problem's at the enthesis, but on the bony side of the enthesis. And we'll discuss that when we talk about the bone. So you really don't get, you don't really get a range of motion, not a great change in the range of motion, but it is an end range. In this case, it's an end range, and we can go a little bit of flexion and end range it. Same thing here, we can do a little bit of flexion and end range it. Many different end ranges on the joint. Not physiological, though, but as I was saying, we're looking where the blood flow is compromised. Patient's response tells us the entire story.